I think the main focus in recent years has been on the genetic causes of male infertility. So we know that if you look at a group of patients who are seen for male infertility, about 30% will not have a diagnosis. And we feel that many of those men have genetic abnormalities. So our laboratory is identifying genes that are causing male infertility and looking for these genes in men with non-obstructive azoospermia. In other words, they're not making sperm. And we hope at some time at least to be able to tell men whether it's worthwhile to proceed with testicular sperm extraction based on their genetic profile. So we're trying to develop a genetic profile with selective genes for these infertile men. I think in terms of treatment, the main thing we're now offering an increased is microsurgical approaches to the treatment of obstruction of the vas, obstruction of the epididymis, and microscopic testicular sperm extraction. So a lot of what we're doing technically has evolved around the microscope. Unfortunately, we don't have any new drugs, and I'm hoping that that will be something in the future. We can identify treatable causes of male infertility that don't require surgery. So there are new genes. I mean, I could mention the name of the gene, but that's not important. It's not what the gene is called. It's the fact that we're now identifying these genes that cause male infertility, and we can then look for them in men with otherwise undiagnosable problems, and perhaps be able to tell them then why they're having problems with infertility. And perhaps some of these genes, especially if they're on the Y chromosome, will be passed on to their sons, and we have to be able to tell them this. There really isn't anything under trial. I mean, there are some directions I would like to go pursue, but there's nothing right now that I could talk about that would be going to the FDA or under trials. The biggest challenge is identifying treatable causes of male infertility related to some type of medical therapy that we can offer. But I don't think it's going to be hormonal. It's going to probably be something related to decreasing the amount of oxidants in the system, or drugs perhaps to stimulate growth hormone if we can identify growth hormone deficiencies. But we don't have any real drugs at the moment that are being tested. It's one of the big issues with male infertility. There's many drugs to help women produce eggs. There really are no drugs for men to help them produce sperm unless they have very deficient hormones. Then we can give them hormones. But that's only it's a very small percentage of men with fertility problems. So currently the team is looking at new genes that we feel may be causing male infertility and trying to develop clinical assays so we can test patients to see if they have these genetic defects. And then we want to see, are these genetic defects predictable of which men will have sperm when you do microscopic sperm extraction? And then another area that we're dealing with is developing understanding the genetics of Peyronie's disease, which is not an infertility problem. It's a problem with erectile function, normal erectile function. So I think the most memorable experience is the fact that I've trained close to 100 fellows, both in the United States and from abroad, who are now out practicing reproductive medicine. And we have four of them who have become department chairmen. So I think my biggest accomplishment is training these other people, because they are the ones who are going to make the discoveries of the future. I would probably, there was a time before I went to medical school that I was interested in being an architect. designing buildings or homes, because I think it's something that's both creative and functional.
Mm-hmm.
So somewhat related to laboratory research, where you're trying to develop tests that will then be translational to the human experience. So I was interested in developing buildings that would be, but I never did it. So obviously that's why I'm here. I would say that, have an open mind when you're in training, in the early years of training, because there's so many different subspecialties in urology. There's oncology, there's female urology, there's pediatric urology, there's male reproductive medicine. And I think you have to keep an open mind in the beginning and maybe make a decision halfway through your residency and then start moving more in that direction. So by the time you finish your residency, you have more of an idea of what you want to be and then can apply for appropriate fellowships to get that extra training you'll need to be competitive in the medical marketplace.